Good morning, students. Hi. I have my Cal State San Marcos mug to hold my coffee this morning. Is anyone else enjoying a nice little cup of coffee? If you're watching this later, probably you're not. Good morning. If you're here, I know I've just posted the link on Canvas, but good morning. Please say it back. Can you believe that it's March? It's March. We started this in early January, and we're in Unit 2 now, and we're in March. Ah, how time flies. Okay. With that sentiment, welcome to Unit 2. We're done with Unit 1, like I said. The subtypes of EPI that we looked at, and also the diversity and equity in the US stuff is over, which means that math is beginning. Math. Including today, okay? Um, Not necessarily this week, but if you have a calculator, I would start bringing it to activity. Um, Ask questions if you have them. I know that I don't think I have any math majors. I've got some there's some econ and CS majors who are math adjacent or use a lot of math, but if you're not one of those folks, don't be scared. We're going to get through it together. And today I'll also preface you. Good morning, Faith. I'll also preface you that we're gonna do some little. You know how I do my Dora thing, and I ask you a question, and then I tell you the answer. We have some Dora math problems, so I'll take extra long and give you extra long to try and do them, and the Dora time will go quicker if you do them along at home, and share your answers in the chat, because then I'll know about how long it takes you to do them. Otherwise, I'm just gonna overshoot and wait a really long time before I tell you the answer. Math is here. More math is coming. That's my welcome to Unit 2 sentiment. Quiz 5 was just due. I know I gave you more time to do it. I gave you a week and the weekend. But this is the record low for people turning in the quiz on time. As a reminder, I'm sure that many of you know this, but I did get a couple freaked out emails. You have 48 hours still to do it unpenalized. You could turn it in by Thursday, 9 a.m., and it's chill. It's fine. No penalties. But I just want to remind you, because there are a record low amount of people who've turned it in thus far, that the ship is sailing forward, and Unit 1 quiz is something you probably don't want to have to think about while we're learning math, right? And with that said, there isn't a quiz this week. I had to check my own syllabus that I made to make sure that this was the case. Because you have an extra credit assignment optionally due on Thursday. It's optionally due because it is extra credit. There's no quiz this week. And because you turned in Unit 1 homework last week, which I know was a large assignment, no quiz this week, but this material will be on next week's quiz. Because it directly feeds into it, it'll be reflected in next week's quiz. So quiz 6 will happen next week. That doesn't mean that you get to click out of this lecture. It just means that if you're one of those people, that opens the quiz to watch the lecture and take the quiz while you're watching, you can't do that. It's try again next week, but still watch this week, preferably. Unit 1 homework will be graded by next Tuesday. You probably don't care. You probably want to leave it in the past. But on my syllabus, I usually, my policy is that I try and have everything back within a week. And I think it's fair to you to let you know when that's not going to be the case. So I know that there's 80 of you now. I have 2 sections. There's 80 of you. So I'm not going to get them back by Thursday. I will get them back by next Tuesday. If you want to know my weekend will look like, I'm going to be sat right here watching disc golf and reading all of your Unit 1 homeworks. Those that I've graded so far have been really thrilling, and I'm really proud to read your submissions. So great job so far. Anticipate grades by next Tuesday. Another thing you can anticipate by next Tuesday is the Unit 2 homework. So this week's activity is a book club. If you do want to come, please only come if you've read the book, or I guess be okay with getting spoiled and adding nothing to the conversation. But there's no need to bring your calculator this week, but next week and for the next 3 weeks, all we're doing is working on that problem set together, iteratively building on it based on what we learned in class. Because it will take the rest of the unit to learn all the skills you need to do the homework. But yeah, it'll be posted next Tuesday so that you know the scope of it. It's anticipated to take the same time as the Unit 1 homework, but it's not a writing assignment, it's a problem set. Okay. I know there was more announcements than usual. I guess last announcement is Happy March. And today's lecture, to kick off Unit 2, is how do we track disease and measure health? We're going to go over review some day 1 stuff, and then it's math. Okay. With the day 1 stuff, we're going to review the definition of epidemiology. You all had to put this on your Unit 1 quiz. And some of you, put like the study of what befalls the people. Some of you put kind of different iterations of this, but if I ask you the definition again, or you're at the dinner table verbatim, this is what you should say. The study of the distribution and determinants of health-related states or events in human populations, and the application of this study to prevent and control health problems. Now, we're doing this a little bit backwards because you've already considered in your Unit 1 homework, you had to propose to me 2 intervention components on different levels to target health disparities, which I'm so proud of you, and the application of this study to prevent and control health problems is interventions, pretty much. Whether that's policy interventions, education interventions, or anything in between, preventing and controlling health problems, usually we're intervening. So this step we've kind of already at least done our think piece on, but again, in Mathland, we're going to go over all these bolded and highlighted in this minty blue words to further break down the definition of epidemiology so that you know what you're saying when you're saying this to people. Let's start with distribution. Distribution is the frequency and pattern of health events in the population. We're referring to the analysis of how health events manifest across different populations, which has its metrics grounded in frequency. Frequency doesn't just refer to the number of health events or cases. It encompasses both this raw number and its proportion in relation to the entire population. So for instance, if we observe 100 cases of a specific disease, 100 cases of arthritis in a community of 1,000 people, arthritis is rarer than this, but we would be looking at a frequency of 10%. Next week, your lecture is called Measures of Disease Frequency. So if you're like, Marina, you just told me a math problem. Yeah. This is the type of stuff we're doing. Frequencies. Number in relation to the population. By understanding both the absolute cases and their proportion, we're better equipped to make comparisons across different populations or even different subgroups within the same population. Right? And you've all looked up magnitudes at this point of health disparities, and these result from, I should be waving my mouse over here, these result from frequencies. Now, the second aspect, pattern, is about identifying the specific arrangement of health events based on various factors. The WHO focuses on personal characteristics. Again, you've done this through your health disparities. We were looking at how a disease affects different age groups, genders, professions, socioeconomic brackets. For example, a certain ailment might be more prevalent among the elderly as compared to younger individuals, or it might affect one gender more than the other. The when dives into the timing of these events. Health issues might manifest seasonally, like the flu, which has a season each year. And you can see that reflected in sorry, this is not what this is at all. You could see it if you were to look at like a yearly trend of the flu. You could see when it crops up seasonally. And we see that reflected in the distribution of when that disease manifests. And And we could be tracking sudden outbreaks or long-term trends where disease gradually becomes more prevalent over several years. And that would build us rationale to intervene upon it. The where zeroes in on geography. The spread of health events can differ dramatically between urban and rural settings, for example, or between countries. And this can do with various factors, from the policy environment to the built environment to literally the natural environment, to healthcare accessibility. These can all play a role in where diseases crop up. And the what delves into the health event itself. We'll talk about case definitions today. For example, if we were looking at all respiratory infections, we could compare which particular diseases we're seeing the most. This is to say, and we've talked about it before, the occurrence of diseases and other health outcomes varies in populations, with some subgroups of the populations more frequently than others. Disparities exist. We've talked about this before. Because if all health things were even and never changed and happened in a constant state and were expected and could not be intervened upon, I wouldn't have a job and public health wouldn't be a field, nor would epi. Right? Okay. Let's go back to the definition again. We did distribution. Now let's talk about determinants. Boop, boop. Determinants. So there's risk factors, there's determinants, and there's causes. So we're searching for risk factors for health-related states or events that are modifiable and non-modifiable. These are things that make a person more at risk for disease. This is a little word cloud of things that could be determinants. I think this is for cardiovascular disease. Yeah. Some of these things are changeable. You could theoretically not smoke anymore. The fact that risk factors is just like the biggest, boldest thing. Maybe this is chronic diseases generally, but it would make sense for cardiovascular disease. But things like over 55, you can't change your age. Unchangeable. Your family history, unchangeable, unfortunately. Your high blood pressure, possibly changeable. So these things can be modifiable and non-modifiable. Things can also be very difficult to modify. I'd put high blood pressure in that. It is difficult to modify, especially on like a long-term basis. Chronic stress is difficult to modify for one person. You would have to remove the stressors from their environment, but that doesn't mean that it's not a non-modifiable factor. Stress is modifiable. That's what I'm trying to say. So, those are determinants. And exposures. You're already an expert in this because I taught you in the first unit about exposures and outcomes. Exposures here are any measurable variable that affects or is associated with health, pertaining to either contact with a disease-causing factor or to the amount of the factor that impinges upon an individual or group. I won't go back to the definition of epi, but the next thing I'm just going to tell you is health-related states. What do we refer to? What do we mean when we say health, when we say disease? Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, according to the WHO, which if you haven't heard about the WHO, you'll hear shortly. Health can comprise any and all of these things. A health-related state can be positive or negative. So, wellness book that you will be caught up to page 290 of by Thursday. Nutrition, exercise, psychosocial, psychological, all components of health. And now we're getting into the bad, scary. Pain, injury, and disability, still components of health. Symptoms, syndromes, conditions, disorders, disease, and death. We still consider health. Especially in the definition of epi, a health-related state, you're like, oh, that must be a positive thing. No, we're still tracking things like vitality, mortality, right? In fact, I'd say even more so. We end up focusing more on the negative consequences as they arise, even though we aim for prevention through these things, right? Boop, 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 boop. health-related states. The last thing we'll go over today in terms of this definition is populations. A population is a collection of individuals at moments in time defined by at least one organizing characteristic. So, you're like, wow, it could be extremely broad. Yes, it could. If it was residents of the U.S., your one organizing characteristic is that you're in the U.S. Even though that's so broad and everyone in the U.S. looks so different. Even Cal State San Marcos students, y'all are pretty broadly defined, but you have at least one organizing characteristic. If I picked Kines majors at Cal State San Marcos, now you've got multiple organizing characteristics. Your major's at the same university, same major, same university, multiple organizing characteristics. And I would want to be specific and say Kines majors in 2024, right? At moments in time, we like to be specific. Although there are ways that you could, it changes what your population is, but you could say all Kines majors at Cal State San Marcos ever. The definition of a population has implications for analysis, interpretation, and generalizability of results from epidemiologic studies. If we were looking at physical activity metrics and free time among Kines majors as compared to, I'm going to rag on math majors because I don't think I have any, math majors, we could analyze that. Who do you think is more physically active? We could test that. It's probably Kines majors. Also for interpretation. Is what is true. If I ran a study on you all, and I'm thinking about doing this in the fall, when I teach research methods, seeing how well Kines majors can throw a disc, something like that. Do you think that the rest of the student body at your university would have the same experience? If I found truths about how good you all are at throwing discs, would that be true about the rest of your university? And that is what we are touching on when we say generalizability. Are the findings that I found about you, like Kines majors, let's say you're all really good at throwing discs, you can all throw 300 feet, and that's very far. Do you think that would be true for other majors? Do you think that would be true at other universities? Even if I got that data from the entirety of Cal State San Marcos students across all majors, do you think that my findings would be generalizable to students at UCSD? Why or why not? In what ways do the population of Cal State San Marcos students look different or similar to UCSD students? What is the mean age of the student body? What is the gender breakdown of the student body? These are all things that would affect my interpretation of the throwing skills. What are the athletic resources? How well funded are the teams of athletes? If I really got all the students, would that be generalizable? Why or not? Just a thought experiment. And populations can be, this is important, okay? There will be questions about this, and it will matter for calculating disease frequencies. Populations can either be fixed, where membership is permanent. You cannot join this group, and the only way that you can exit this group is to die. Okay? A fixed population, an example, and we'll define this. Next slide has all the definitions. But an example would be if you were present in Lower Manhattan on the morning of September 11th, 2001. I once worked at a Belgian cookie bakery. Sorry, I'm going on a tangent. I once worked in a Belgian cookie bakery, and her first time in the United States, she went to go visit her now husband, who was a banker in New York City, and she went on a walk in New York, and that was on the morning of September 11th. She is alive, and she was far away. She didn't see it happen, but she, like, people were freaking out, and she was like, oh, this is just what New York is like, because it was her first time in the country. But no, it was 9/11. So membership is permanent. You are either there, so she would be a member of this population, or you are not. No one can enter this population. Do you understand? And the only way to leave it is to die. Versus dynamic populations. Most populations are going to be dynamic, and you will, that's going to complicate the math that you have to do, so you're going to regret that, but most populations are dynamic, where membership is transient and can be defined by going in or out of a state. For example, residents of Corvallis, Oregon. I had a friend who lived there for his master's. Now he doesn't anymore. He entered that population and then subsequently left it. Does that make sense? Let's go over the definitions. So dynamic allows movement in or out of the population. A person is a member of the population as long as they meet the definition of the population, and they cease to be a member of the population when they no longer meet the definition. For example, if you wanted to survey grad students, I'm willing, Lord willing, only going to be a member of that population for 2 more years, and then I will no longer meet the definition of that population. For example, people that may move out of a geographic region, people with a certain occupation, like a firefighter. You could become a firefighter and then you're in the population of firefighters, but then you can retire or leave your job and do another job. You could also leave, come back in. That's a dynamic population versus a fixed population that do not allow movement in and or out of the population, often defined by some event, whether it's something like 9/11, or it could be like you received a tetanus shot in 2003. You either did or you didn't, and that's that. Once a person experiences the defining event, they remain part of that population as long as they are alive. For example, population may include all those born on a particular date and only following them forward in time, never losing or adding any others. So yeah, so if we define this by time, it becomes much easier to make it be a fixed population. People who ate oysters in Pacific Beach in January of 2024. That'll be a relevant one. Okay, so that's the definition of epi broken down into its parts. And now, we're going to get into it. This lecture is called How Do We Track Disease and Measure Health? Let's talk about tracking disease. So we defined health-related states, but disease was one of those bullet points. What is disease? Disease is a term that encompasses a broad range of conditions affecting both plants and animals, including humans. At its core, a disease represents an impairment of normal bodily functioning, okay? Often accompanied by signs and symptoms, which you know what those are, and the difference. Whether it's a disruption, complete halt, or disorder of the body's functions, systems, or organs, disease hinders the natural and usual operations of the organism. We're concerned with human populations, that's why that's in the definition as well. And the causes of the disease can be multifaceted. So, yeah, if anyone asks you what disease means, it's this: an interruption, cessation, or disorder of bodily functions, systems, or organs. And we've talked about different ways diseases can arise. 2 broad types of epi are descriptive and analytic. This is from your first week of class as well. In descriptive, we're not looking at associations. Next week, this is true. Yes. This week and next week, we'll live in the land of descriptive epi. And then we'll jump into analytic epi. So for the next 2 weeks, we're just examining the distribution of diseases in a population and observing and describing the basic features of its distribution. Who is getting sick? Then in analytic, we can look at the why and how are they getting sick, right? Because now we can look at the exposures, we can look at associations between exposures and disease outcomes. So we talked about this who, what, where, when earlier. We're in the land of descriptive epi, and when we jump into the land of analytic epi, I'll tell you again. In descriptive epi, again, we're looking at patterns, generating hypotheses, informing public health strategies, looking across time, place, and person. Let's operationalize this example. Say I'm thinking about injuries due to falls. I could look at the time of cheerleading practice versus the time of them performing or like competing or cheering at games. Excuse me. I could look at cheerleading practice in high schools in the United States, not looking at colleges or nothing. And I could look at cheerleaders aged 13 to 18, assuming that's the population of high schoolers. And I could identify patterns. This data isn't disaggregated to that exact time, place. I'm sure there are studies that have that, but We could look at patterns. Across the 10 leading causes of non-fatal emergency department visits in the United States, we might hypothesize that this is an important descriptive study that we need to do, because look at this. You might have to make your screen really big. But in our population we have 13 to 18, so that is kind of this and kind of this. What is the number one leading cause of non-fatal emergency department visits in the United States? It's an unintentional fall. Now, this could look like Dre Greenlaw tripping and falling on the field at the Super Bowl. It could also look like this. So we would want to disaggregate that further, but we can say this and build rationale to study this, right? And then here are the other reasons. You can look at those if you find those interesting. Okay, so I probably should have showed you this before you all turned in your first example of writing, but it's okay. I see a lot of people misusing these words. Let's just define them and operationalize them for you. Something that is endemic refers to the constant presence of a disease or infectious agents within a certain geographic area or population without importation from the outside. What's endemic, you can kind of see here, is like the usual, expected, normal level of disease. So, like malaria is not endemic here, but malaria is endemic in many parts of sub-Saharan Africa, and people living in these areas have a consistent risk of contracting malaria year-round. We'd say that malaria is endemic there. It's not endemic here. An epidemic, okay? People in their hooks for public health papers like to say, like, oh, obesity is an epidemic, A, B, and C is an epidemic, smoking is an epidemic, vaping is an epidemic. Some of those might be true. Vaping especially, actually. When the level of disease, and we've defined disease before, also those are all behaviors. Vaping is a behavior. So maybe not. You could say EVALI, which is the vaping lung injury, is an epidemic. When the level of disease that occurs in excess of what is normal for a population. Right? For example, there was an outbreak of Ebola in West Africa, 2014 to 2016. The disease surged in Guinea, Sierra Leone, Liberia, and it resulted in 28,000 cases and more than 11,000 deaths, which is well above the typical number of cases seen in this region. So that was an epidemic in West Africa. Here, they have an epidemic in excess of normal. 1 case of rabies in Newton. I don't know where Newton is, but yeah, apparently they never have rabies, and 1 case would constitute an epidemic, okay? But you have to have established what is normal, what is endemic, and then what is epidemic. Epi meaning on top of, right? And then finally, pandemic. This is an epidemic that occurs across many regions or even the entire world. So, they said that the COVID pandemic is over. They being the WHO, okay? But COVID still exists. And we can think about this operational definition when we consider that. Yeah, this is an epidemic that is spread to multiple countries or continents, usually affecting a large number of people. For example, the COVID-19 pandemic, you all lived through it, and it was declared a pandemic in March of 2020. I need a little 5-minute break. I need a little bio break. I'm gonna get some water, go potty. I'm gonna put on the starting soon screen, but I'll be back in about 5 minutes. Sound good? Get up, get a little snack. Or if you're watching this recorded, skip 5 minutes. Whew, okay, welcome back. Oh, can you see? You have a TA sitting on the bed. Here, let me just check. Yeah, you can see him. Say good morning to your TA, Milo. Okay, picking up where we left off. Pandemic, you know, all know the example of. How do we observe these things? How do we find out what's normal in an area? How do we find out that excess cases are cropping up? We find out through public health surveillance, which is the ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. I'll pause right there. Right? How do we know if we're doing a good job? How do we have these data? We're going to start doing math. You'll be like, how do we have these data to know if my intervention is effective? Like, yeah, we could throw shit at the wall and see what sticks. But we have to have documentation that something is sticking, that rates are decreasing, that something is associated with either an increase or a decrease in disease states in a population. We know that through public health surveillance. We have to collect data so consistently that we can track all the changes that we purport to see, right? So that's closely integrated with the timely dissemination of these data and to those responsible for prevention and control. I impressed this more last semester, but I think my students didn't really get it. The CDC, which you'll learn about what that is if you don't already know, the Centers for Disease Control, they drop a morbidity and mortality weekly report. Every 7 days, they talk about what's going on in the world of public health with the newest, hottest, freshest data. It's not every single outcome every week, but it is weekly that we get these updates. With the goal of providing information that can be used for health action by public health personnel, government leaders, and the public to guide policy and programs, right? If we have an intervention that we have figured out works, we want to scale it up, make it into policy. And if we have things that we know are causing unequal disease, we want to develop programming to prevent those disparities like you hypothesized, right? Uses of public health surveillance are to identify patients and their contacts for treatment and intervention, right? Contact tracing. We talked about this last week, and I will say it was a thing before COVID. We talked about it in the infectious disease week. We didn't talk about it last week. We talked about it in the infectious disease week. The goal is to prevent community spread of a disease, right? But it can also be to get the people that need to be in treatment. When I was getting my MPH at Yale, I had roommates who worked for like the food corps of the Connecticut Department of Public Health. So while we were all in lockdown, they would be calling people and saying like, "Oh, what color was your poop? When's the last time you pooped? Have you vomited in the last week?" And asking their contacts the same things, and they were like, "Okay, what did you eat at the party? Can you give me a food diary of what you ate and did not eat?" Eventually, they did this so often, and I heard this every day. They did this so often that one of them was able to trace back a foodborne outbreak to a cruise ship and get the cruise ship to respond and get patients treatment. So that's what contact tracing looks like with foodborne illness. And there's the question that I asked about oysters. It'll come up again. Public health surveillance can detect epidemics, health problems, and changes in health behaviors. Like we know that people are vaping now. A, from looking around. B, on our side, market research, they know how much e-cigarettes are selling. But we want to know how much people are using. So we have to keep up our own. We have to surveil changes in health behaviors. Detecting epidemics, like I said before. We know what's endemic, and then if we see those cases crop up, we're detecting an epidemic by surveilling. Estimating the magnitude and scope of health problems. Sometimes we get this wrong, but if you've taken research methods, if you know what a regression is, yes, we use it to find associations, but technically regressions are predictive models. People can model, like, oh, if there were this many cases cropping up over 3 days in these three people, we expect to see an epidemic coming. They can predict those things using predictive modeling. You can measure trends and characterize disease, monitor changes. It should say in infectious and environmental agents. There's more ticks at the park than last year. I have a friend who she got like a cross degree from the Yale School of the Environment and the Yale School of Public Health, but her job was to like go pick up bugs off the ground, like to survey the bugs. She would go and she'd put little bugs. She would ask for all our jars because she had to bring jars of bugs back and test the bugs. Assess effectiveness of programs and control measures. We'll look at how to do this. Develop hypotheses and stimulate research. We think that might be why people are getting sick. We're going to test them using the data that we get from surveillance, right? 2 types of surveillance are passive surveillance and active surveillance. Passive surveillance is when diseases are reported by healthcare providers, of like, oh, this patient is coming by themselves. We found that they're sick, so we gotta go tell the CDC or the local DPH that will tell the CDC. This is simple and inexpensive because people are basically reporting themselves. That's what they mean by passive. They're just appearing sick and we can count them. Very easy. Simple and inexpensive, but is limited by incompleteness of reporting and variability of quality. Some healthcare providers might forget. Some medical scribes might forget. Some people might not have access for things like norovirus, which we'll talk about more, go to a doctor. So some cases might slip through the cracks of passive surveillance if access is an issue. Your other TA is now in the background. Say hi to Mimi. And then active surveillance, which is when health agencies contact health providers seeking reports. For certain diseases of certain severity, passive surveillance exists, and then for others, active surveillance exists. I think I have, on the next slide, I have a website link, and you can see what the reportable illnesses are and whether they're passive or active, I think. Where health agencies contact health providers seeking reports. Hey, how many people appeared at your lab with Giardia this week, perhaps. And this ensures more complete recording of conditions and is used in conjunction with specific epidemiologic investigation. Right now, with norovirus, there is an outbreak in San Diego in January. And so now they're trying to do investigation. So they're asking people in like San Bernardino and Ventura County who ate those same oysters if they had cases of norovirus crop up. So that's the difference. This is the disease reporting pathway, is that all roads end with the CDC. This is like a perfect and also imperfect model. The CDC has its own biases and is imperfect in a lot of ways, and our best marketers, our best publicists are all in marketing and are not in health communications. Therefore, the CDC has recently lost a lot of trust in a lot of people. But they have the data. One thing that they have is the data. Where healthcare providers report to local health departments, you could go work if you get a degree in public health for like a county health department, or you could work for CADPH. I have students who are trying to do this at UCSD. And then they report to the CDC. Labs too can find like, oh, certain infections were in people's urine. Institutions, if I was doing research and I had a reportable illness based on this, I don't do infectious disease reporting. But I would report to my local health department and others. And all roads end with the CDC. Okay, let's talk about disease reporting in the news. I guess this isn't really the pathway at all, but these are how the data come to be. Was it last week? For the infectious disease epi portion, I asked you that question, and it confused a lot of you, of like, if we were having oysters together in Pacific Beach and we both got sick, what type of transmission is this? The answer is horizontal because I'm not your mom, and it's indirect. If it was because I was breathing on you, if I had the disease and I gave you the disease, that's direct. The oysters had the disease. We both got it from the oysters, shared food source. Excuse me, so that's indirect transmission. In mid-January this year, at least 41 people, at least, right, because there might be more, we don't know, 41 people in San Diego County fell ill with norovirus a day or two after eating raw oysters. They got all of this information through surveillance. In response, the FDA issued a warning to restaurants that oysters recently purchased from Mexico might have been infected with norovirus. This is about... this article was about, like, norovirus all over the country. This article is about that outbreak specifically, if you want to look into it. And here is... this is, like, far above what is endemic in San Diego, right? Here are the norovirus outbreaks reported to the Epi Unit, disease reporting, in our county for the last 10 years up until now. You can see in 2020 what happened. The total norovirus outbreaks were very low. Very low. Because people weren't going outside. But the percentage of norovirus outbreaks in congregate living settings went way up. So these are folks who were trying to prepare oysters at home. Probably left them out of the fridge for too long and then the virus went crazy. Does that make sense? And then here is what is kind of expected. You could calculate a mean from all of these and figure out what is endemic. And then 41 people, they found an outbreak. This very early in the year, we might see an epidemic of norovirus this year. Who's to say? But that's what they do with these data, right? And this is how they come to be. Okay, I've already touched on this, but the Centers for Disease Control and Prevention. It's kind of fucked up. Sorry, I shouldn't say fuck. It's kind of messed up that they leave the prevention off. The prevention is the key, right? Prevention. We love prevention. But Centers for Disease Control. They added prevention, I think, more recently. The CDC's mission is to protect public health and safety by controlling and preventing diseases, injuries, and disabilities in the U.S. and internationally. It was established in 1946, and their main office is in Atlanta, Georgia. I have friends who work for the CDC and do evaluation for the CDC. They all live in Atlanta and enjoy it. And they operate under the Department of Health and Human Services. This is somewhat important. You know the fucking food pyramid? I'm having my second coffee. I'm swearing too much. You know the food pyramid? What department of the U.S. government puts that out? I'll tell you. Dora style. It's the Department of Agriculture. Don't you think that the Department of Health and Human Services, who have all the data, would have a better idea of what we put on our plates? Or what we should put on our plates for our health? Because what's the USDA's priority? I'll let you think about that. And then the Morbidity and Mortality Weekly Report. I did tell you about this. We're surveilling so constantly that we can drop new data every single week. And they do. And I have colleagues who've been authors on these. And you can... Here, I don't know. Let's see. Boop, boop, boop. CDC. MMWR. Homepage for the MMWR. What do they got? They're probably way above your scientific literacy and possibly even mine. Oh, sad. They have deaths from excessive alcohol use. This February 29th one, last week. Again, they have a whole big old team of authors because it takes a village. I don't even know what this is. Oh, vaccines. Monovalent vaccines. And urgent care encounters. Among immunocompetent, so not immunocompromised. My plate is still the USDA. So they're talking about COVID. This is their latest COVID data that they're dropping. So every week they do this. It's not always COVID. It is Oh, that's sad. Sorry, I don't want to go over that. Behavioral surveillance among trans women. This is HIV, so that's relevant to me. But yeah, they're dropping this weekly. It's a weekly report. Last semester I made them read them. I'm not gonna make you do that. Just know what they are. The NIH, National Institutes of Health. If you go into a health profession where you are seeking grant funding for any research, the biggest body that does that, this is America's Medical Research Agency, is the NIH. Right? They're institutes. Don't say National Institute of Health. There's several of them. In fact, there's 27. Right? So this is the primary federal agency for conducting and supporting medical research in the US. If one of your professors tells you that they're working on a grant, they're probably writing a grant for the NIH. And you have to apply to a specific institute or center. These are just 4 of the 27. Now, you'll notice that these are all outcomes. National Cancer Institute, Institute of Allergy and Infectious Diseases, Heart, Lung, and Blood, Mental Health. They have one now that's like for minority health and health disparities. I think it's NIMHD. NIMHD. That one is kind of groundbreaking for a reason that I find interesting. When you apply for a grant, they're outcome specific, right? This is an outcome. These are outcomes. I just spent the entirety of last unit trying to tell you that nothing happens in a vacuum and that a lot of the social determinants of health are common exposures, right? I have a colleague from my master's who does housing research. She just wants to look at housing as an exposure and figure out what outcomes it's associated with. I'm a violence researcher. Same thing, right? I'm looking at violence as an exposure and trying to see what different things it's associated with. And it synergizes with a lot of things to produce disparities, right? But when you apply for grant funding, you have to pick one. They tell you, no, you got to pick one outcome that you think it's associated with. You can't just look at the exposure and look at disadvantage that way. You can't. So that's where the siloing comes in. Different institutes, multiple institutes. Research funding comes through the NIH. And I probably shouldn't slander the people that I'm asking for money on Maine, but they're a little bit behind the times. We live in a digital age, and even still you have to send in like paper copies of your grant, and then people have to fly in to review paper copies of your grant, and it all takes a very long time. So that's the NIH. And then the WHO, this is so many words. The World Health Organization is the UN agency that connects nations, partners, and people to promote health, keep the world safe, and serve the vulnerable, so everyone, everywhere can attain the highest level of health. Sounds pretty good, right? Good deal. They're established in 1948. They're in Geneva, Switzerland, which is a very, very fancy area of Switzerland. And you're in Switzerland to begin with. These are all the things that they can do, but one thing that they can't do is make laws. They can make formal recommendations. They can campaign. They can monitor health situations, right? This is really important for global understanding. Surveillance can tell us so much. I do think politicians of recent memory have tried to denounce or divest from the WHO, which I think is a really bad idea for all these reasons, because they can't make laws. It is ultimately up to each nation's government to enforce or not, to participate or not in the WHO's activities and recommendations. All right, disease stages in individuals. I probably should have put this back when we talked about disease. Just know that clinical can be characterized by signs or symptoms, or non-clinical. We talked about this before. We talked about it in context of infectious disease, but probably not chronic disease. Preclinical is the phase between infection or exposure and the development of clinical symptoms, so it will become clinical. Subclinical is when the disease does not produce signs or symptoms and will remain that way. So like herpes, you might have the herpes virus but never develop cold sores or any other symptoms, even though you might carry the virus. And then chronic disease persists for years. It could also refer to clinical disease. So, like, clinical chronic disease could be diabetes, where patients experience symptoms like you pee a lot, you're very thirsty, and you can experience unexplained weight loss. Or like hepatitis B is a chronic disease that can be subclinical. Um, it stays with you. You can be a chronic carrier of it, still transmit the disease to others, but have no symptoms with hepatitis B. Okay, so those are disease stages in individuals. Other key terms that you have to know are an outbreak. I've used this term already a lot today. Similar to an epidemic, but usually refers to a more localized increase in the incidence of a disease. So, like the norovirus, the oysters, that's an outbreak of norovirus. Traced back to a single contaminated batch. And then a cluster is a grouping of cases in a defined area or time period, group of cases that might be more than expected. For example, a group of students in a dorm coming down with similar respiratory symptoms within the same week might be identified as a cluster. That's still interesting to public health officials, even though it might not be an outbreak of a disease that we can diagnose. And then a rate. We'll go over this more next week, but a rate is the number of cases occurring during a specific period. A rate has to have time in its formula, in its calculation. That's why that's underlined. So in next week, I'm going to ask you if something is a true rate or not. And if it has time in the equation, it's rate. If it doesn't, it's not a true rate. Always depend on... excuse me. And this is always dependent on the size of the population during that period. We'll go over exactly what this looks like later. It's math. Okay, we've tracked disease. Now we're measuring health. A case definition of like a health state. Case definitions should include criteria for person, place, time, and clinical features, and should be specific to the condition under study. So a person describes the key characteristics the patients share in common and exclusion criteria. If we want to exclude people with heart disease, if we want to exclude people with underlying risk, like insurance companies often do. Place typically describes a specific geographic location or facility associated with an outbreak. Right now we're saying like with the oysters from Mexico. Excuse me. Time is used to delineate a period of time associated with illness onset for the cases under investigation. So like for the oyster outbreak, January 2024. Limiting the time period enables exclusion of similar illnesses which are unrelated to the outbreak of interest. We don't care if you ate some poke in February and got norovirus, if you were the only one. In the terms of our outbreak, we'd want to define people as those who ate the oysters in January of 2024 from that batch in Mexico, right? And clinical features describe signs and symptoms presented by patients. If everyone's puking, that would be a clinical feature. Really, it would. Example. I've used the real life one, but here. Cases consisted of guests aboard the Sequest cruise ship who developed onset of fever accompanied by vomiting or diarrhea between July 7th and July 20th, 2015. That should make sense. In practice, I have a couple, these are both COVID. Nope, this is injury. This one is COVID. They're talking, they have the time up here, right? They're asking long COVID questions. So they're like, respondents reported previous COVID diagnosis. That's their inclusion criteria. They tell us how to operationalize it. And possible symptoms. Significant activity limitation from long COVID. So this is how people are beginning to define long COVID. And they try and build up the elements of a case definition. And this is US. They say that because they're talking about the Census Bureau. Here, this is, I used to assign this reading about high school sport and concussion. Here, they give their case definition in the article. Our injury of focus concussion was defined as occurring as a result of participation in an organized practice or competition, requiring medical attention by an athletic trainer or a physician, and being diagnosed as a concussion. So, if you got a concussion in class, we don't care. even if you're a high school athlete. It had to be as a result of participation in an organized practice or competition. It has to have been diagnosed. If you had a concussion but you were fine, you played through your whole game, and then your mom just did the thing where she wakes you up throughout the night to make sure that you don't have a brain bleed, that wouldn't count either. This is how they're defining their case definition. Does that make sense? How do you measure disease patterns? Two things that we like to look at, I've used these words both a lot in the lecture already, are mortality and morbidity. First, we're going to talk about mortality. I've impressed life expectancy to you already in this course. We're going to get into the nitty-gritty numbers of it. An annual mortality rate is just how many people die in a specific region or area or within a certain population that year, throughout 1 year. How many people were there in the population? How many died? That's your annual mortality rate. And you would, of course, track that annually. We'll go over some specific mortality rates, so don't worry about these right now. You'll get the slide very shortly. And then morbidity, we'll also go over. Right now, we're in mortality land. Oh, excuse me. Mortality is one of the major measures of disease in the population, number of deaths in a particular population. Here's the age-adjusted death rate for the 10 leading causes of death in 2021. I've shown you the data from 2019, and I told you that COVID was number 3. Here's the depiction of that, where it even increased in 2021, the death rates. And it's standardized by age, so you're more likely to die from heart disease if you are older. But unintentional injuries shoot up because they're age-adjusted. So they factor out the bias for kids to die this way. And it's still the number 4 leading cause of death. Because it encompasses so much. Then stroke drops down to number 5. CLRD, Alzheimer's, diabetes, chronic liver disease, cirrhosis, kidney disease, super sad. So those are the 10 leading causes of age-adjusted death in the United States in 2020 and 2021. Oh, that your TAs are cuddling. Okay, the next slide is very important, and I hope that you're able to Control F this, even though it's a screenshot, because this is the only time I'm going to give you this, and this is math. Okay. Buckle in. Crude mortality rate. Crude means in the total population. Like a crude rate of something is just in the total population. Crude population is just the number of people in the population. That's what the word crude means. So crude mortality rate is the number of deaths in a time period. This is a true rate because time is part of the equation, right? Over the total population. That's crude. Cause specific. People mess up cause specific to proportionate mortality. So cause specific is more a subsect of a crude mortality rate, right? Cause specific mortality is a number of events of a specific type in a time period. So motor vehicle deaths in a total population at risk. If you never went into a car, you probably wouldn't be considered at risk. We'll talk about population at risk shortly. Age-specific rate is what it says. It's the number of events in a specific age group in the time period over the total number in that age group. We wouldn't look at, like, teen overdose as compared to adults. We'd look at teen overdose deaths compared to all teens, for example. Okay, proportionate mortality. This is what people mess up with cause-specific, so take extra care to get this right. Proportionate mortality is the number of deaths due to a specific cause, right? That's why people fuck it up with cause-specific, over the total number of deaths. Here we're looking at the population at risk. Here we're looking at the proportion, right, of deaths of that cause due to total deaths. That's the proportion. And that helps us better understand the burden of diseases to a certain reason. The proportion over the deaths, total deaths. Case fatality rate is number of deaths among persons with disease over the number of persons with the disease. The case fatality rate for the oysters, 0. 41 cases, 0 people died. 0 over 41 is 0. Got it? So you don't have to be too scared. versus COVID, lots of people have gotten it and plenty of people have died. It's now the number 3 cause of death. Case fatality rate for COVID, pretty high. And then infant mortality. When we're talking about an infant, we mean someone under 1 year of age. Beyond that, they're a toddler, I think, in the literature. Yeah, so we're looking at the number of deaths in babies, infants, under 1 year of age over the number of live births. Okay? I hope you have your slides up because I'm going to give you a problem and you need this equation. Here is your problem. In 2020, 106 babies were born among 6,376 people in a town in California. 3 infants died before the age of 1 due to infectious diseases, and 1, under the age of 1, died in an accident. 3 children ages 2, 3, and 7 died due to other causes. What is the infant mortality rate per 1,000? I'm going to give you a lot of time to do this. I'd love to get a brave soul to try and answer in the chat, and it's okay if you're wrong. All right, students, not all at once. All right, I'll give you 2 more minutes, and then we'll do it together. Any brave souls watching the stream want to try and put their answers in? Okay. It's Dora time. Going once, going twice, Dora time. So what are the distractors? Let's go back really quickly. What's the equation that we're using? Number of deaths under 1 year in time period over the number of live births. So what are the distractors that I added? What are the distractors that I added? What are some numbers that I gave you that are totally irrelevant to us doing this problem? We care about the live births. 106 babies were born. That will be our denominator. It's totally irrelevant how large the town is. This number, useless. And our numerator is what? Deaths under 1 year of age. We have 3 and we have 1. So our numerator will be 4. But I told you that 3 children ages 2, 3, and 7 died due to other causes. Do we care? I mean, in principle, yes, we care about child deaths. But for the purposes of this problem, no, we don't. So again, Number of deaths in under one time period, 4. Excuse me. Over the number of live births, divided by 106. And then I asked you in the question, per 1,000 live births. I didn't tell you live births because you have to check the equation. You're like, Marina, I don't understand. There were only 106 babies born. How would we know the number per 1,000? You figured out the rate. The rate is hard to interpret in this form. So to ask you per 1,000, now we know what the rate would have been per 1,000 live births. So our answer here is 37.74 deaths per 1,000 live births. Does that make sense? Do we understand how we got here? I'm happy to take questions on that. Okay. But we are going to move forward to morbidity. Morbidity, the two main metrics are prevalence and incidence. We have point prevalence and period prevalence, and then with incidence, we have cumulative incidence and incidence rate. These are going to become your favorite words. You're like, oh, there's only 2 types of each? Awesome. You're going to hear these forever now. Prevalence is the number or proportion of people who have a particular disease. If you have diabetes, you are a prevalent case. They are existing plus new cases out of the total population for a given time period. If you had a parent who had cancer but they're in recovery, congrats, they're not a prevalent case. People living with HIV and the infection in the US is 1.2 million as of 2012. They're prevalent cases. There are 1 million prevalent cases of HIV. And this is a measure of the burden of disease. How much of the population does this impact is the prevalence. Versus the incidence. We're looking at incident cases, and what we mean when we say that is the number or proportion of new cases of a disease in a certain time period. We switched the class online to Zoom, or we didn't go to activity a couple weeks ago because we got notified about COVID. There were probably 4 or more incident cases of COVID in this class 2 weeks ago. For the HIV example, in 2012, people were newly infected with HIV in the US were 50,000. There were 50,000 incident cases that add to these prevalent cases. This is a measure of disease risk. We're watching people get sick so we can estimate risks from this. This is helping us understand people's risk. Point prevalence. Like I said, there's 2 of each type. We're starting with prevalence. Point prevalence. Time can be a single point or an interval. So like with the 1 week prevalence, that's still a point. But time is part of the definition, not the calculation. So these are not rates. Okay. This would be those with the disease at a single point in time or a calendar date. How many of you have COVID today? We could know how many prevalent cases of COVID there are in this class. And this is fixed point in the course of life events that varies from real time. It could also be a fixed point in the course of life events that varies in real time from person to person. How prevalent was HIV at birth in Porto Alegre, Brazil? Right? All these folks weren't born on the same day, but we're looking at the at birth point. So that would be a point in the course of life events, birth, that varies in real time from person to person. During pregnancy could be a point. And this is what we think to be a snapshot. I could give you all a survey today about your respiratory symptoms, and we could figure out the prevalence of respiratory symptoms in the class. Versus period prevalence. Same things. Period prevalence is a more confusing concept and is kind of difficult because when does a point become a period? I could capture it in the last week and I would still consider that a point, but then period would be a year. I will not make you calculate it, but please know what it is. Those with the disease during a specified time period. So, in all of 2024, the prevalence of COVID. This would be a calendar time or a lifetime event. Includes cases existing at the beginning and new during a specified time period. You would all be prevalent cases in 2024, even though some of you have recovered from it. Yeah, so it includes people who had diseases sometime during an interval. So point, I want you to think of a single point in time, and then here I want you to think of a period or an interval of time. Here are some examples. I may be interested to know the prevalence of arthritis in a community. So you can visit every household in that community and ask, do you currently have arthritis? Have you had arthritis in the past 10 years? Here you'd be getting at the point prevalence of arthritis. Do you have it right now? And here you could estimate the period prevalence of arthritis in the past 10 years. And these would be the numerators for point prevalence and period prevalence, respectively, when divided by the number of people living in the community, your source population. You're like, Marina, this is math already. This is what we're doing next week as well, is calculating these measures of disease frequency. So if I surveyed all 10,000 residents in a town in 2012, and 1,200 reported currently having arthritis, they said yes to this question. They're my numerator. Over my denominator is my source population. The point prevalence is 12%. If 2,500 people said yes to this question, they had arthritis in the past 10 years, then that's 2,500 over my source population of 10,000. And then my period prevalence be 25%. And of course, all these people are in this. All my point prevalence people should be captured in my period prevalence because the point is part of the period. Does that make sense? Does that better operationalize the difference between these two prevalences? I hope it does, because now we're moving on into the land of incidence. Ooh, this lecture's getting long. Cumulative incidence. You will like this one a lot more. Indicates the proportion of a population that will acquire the disease during a defined time period. This is the probability of developing disease during a stated period of time and is a measure of risk. How many people are getting sick? However, I'll teach you how to calculate it next week, but it does assume a fixed or closed population. A fixed or closed population, remember, these are the ones where no one's entering and no one's exiting. Like was in Lower Manhattan on the morning of 9/11. So if I have a dynamic population, which most populations are dynamic, like a classroom of students, you'd think like, oh, Marina, you have us enrolled for an entire semester. You can't follow us up for an entire semester. That wouldn't be considered a closed population. No, not all of you are in class every week. Some of you might drop enrollment. You're not in it until you die, right? You won't always be my students. I hate to break it to you. I hate to think about it too. But you're not a closed population. So I couldn't calculate cumulative incidence unless I was able to observe you for an entire period of time that I was interested in. The longer the time period, the more this assumption becomes a problem. Thinking about my students. If I reached out to my students for fall, not all of them would follow up with me. I could probably get you all to answer because I'm getting you all to do assignments and stuff. But the longer the time period, the more that the assumption that I could contact, each and every single one of you as a closed population becomes more complicated. It also assumes that the population remains at risk for the entire time period. Okay, incidence rate, you will like this a lot less. With an incident rate, disease occurrence is related to the amount of time that each person is observed. Incidence rate is the number of new cases, the incidence, per unit of time, so it is a rate. And the denominator is a combination of the number of people and the amount of time. It's called person time. I'm just going to tell you now, probably next week, our activity will just be calculating person time. You can either have a fixed closed or a dynamic open population. We'll talk about how people can contribute different periods of time based on how long they're followed up for or that they are at risk. Most people contribute time to the denominator. You can't just have people that are contributing no time to the denominator. Otherwise, they're probably not in your source population. This equation looks like this. And you don't freak out. Don't freak out. This will not be the only time you'll see this. We will deal with this next week. So just know what these are now. Is that incidence rate is new cases during a certain time, and then at the denominator is the total person time at risk. I haven't taught you how to calculate this yet. I'll teach you next week. Okay? Cumulative incidence is the number of new cases during time, and the denominator is total population at risk at the start of the observation period. But if too many people fall off, you can't do this anymore. Okay? So those are the two types of incidence. Now you're like, Marina, you keep saying at risk. I cited immortality as well, population at risk. Who's the population at risk? This would be people who don't already have the disease. If I have COVID, I can't get COVID. I have it. I'm not at risk. If I have cervical cancer, I'm not at risk for cervical cancer. I already have it. I can't become an incident case, right? If I'm already a prevalent case. Does that make sense? And then people who aren't already immune. If you are, an immune can look like several things. I'm immune to testicular cancer. This is my joke that I like to do with susceptibility and immunity. I'm immune to testicular cancer because I don't have testicles. Other things I'm immune to. If I got a hysterectomy where they take my uterus out, I would be immune to uterine cancer. Even as a female. So that should be considered in your population at risk. Other things. If you get vaccinated for something that gives you immunity, you are immune. So for chickenpox, you get it once and you're immune. Denominator for chickenpox would not include people who have natural immunity, who have it at the start of the time period, and wouldn't include people who have already had it because you're not at risk. They develop natural immunity. Oh, excuse me. And this isn't just distribution dependent. Like, I could still get Alzheimer's at the ripe age of 26. I'm not immune. Even though I'm not the target population for that disease, I'm not immune. I have a brain. It could, develop the sulci or whatever happens in Alzheimer's. But immunity would mean, like, you literally cannot get the disease for whatever reason. Does that make sense? Including the fact that you already have it. Okay. We'll talk about the concept of person time as well. We've talked about elements of the denominators of incidence. We'll talk about person time and do I have it? No, I don't. Okay. I'll show you how to calculate it next week. Person time is an estimate of the actual time at risk in years, months, or days that all participants contributed to a study. In most studies, people are followed for different lengths of time, and people will get the health outcome at different times during follow-up. And what happens when they get the outcome? They're no longer at risk. Okay? So, when people get the health outcome at a different time, they stop adding to person time because they're no longer at risk. So if I follow all my students up for a year, and 4 of you get COVID, for those 2 weeks, you are not giving me person time because you're not at risk. When you get better, you're at risk again, and now you're adding person time to the denominator. Does that make sense? We'll look at graphical depictions of this next week. But we can do this in our dynamic open population. People can leave entirely, and then they just aren't adding at-risk time if we can't follow them up anymore. If people die, they're not adding at-risk time to the denominator. Again, these are the assumptions. Why do we need incidence and prevalence? Because they're different things. Prevalence tells us about the total disease burden on a society, whereas incidence tells us whether the number of new cases is increasing or decreasing, and focuses on measuring the transition from health to disease. So we need that to understand risk, and it's a big clue on whether there's an epidemic. If prevalence is a lot higher than incidence, people are living a long time with the condition, and we could call it a chronic disease, like back pain, like diabetes. And if prevalence and incidence are similar, people are either recovering quickly or dying from this disease or not. Number of people living with the disease is similar to the number of people who just got it recently. Any visual learners in the class, you're going to like this. This is the epidemiologist bathtub. Where prevalence, imagine the amount of water that's in our tub. These are all the prevalent cases. The drips coming from the faucet are people who are getting the disease, right? They're going from health to disease. So they're adding to the prevalence. You're like, okay, well, doesn't the prevalence just keep going up and up and up with incident cases? No. There are 2 ways that you can not be a prevalent case anymore. Actually, there are a few ways. You could leave the source population entirely, which we'll talk about, but if you want to not be a prevalent case anymore, you could die. That's a great way to leave the tub. Or you could recover. So this is like the steam in our extended metaphor that's coming out the bathtub. And then our prevalence would go down if we have less people with that disease because they've recovered or died. I hope that this gives you a better image of the relationship between incidence and prevalence. Factors that increase prevalence would be longer duration. If you have diabetes for 10 years, you're in this bathtub for longer. Prolonged life without cure. Like HIV, we can't cure people yet, but we can give them a positive quality of life and make them untransmittable. So there are a lot of prevalent cases that are untransmittable. Increased incidence, like I said, if this rate goes up, your bathtub's going to fill faster. Where cases in migrate, if our source population is San Diego County, and we had a whole bunch of norovirus patients from San Bernardino come, they wouldn't count as prevalent cases. It's like a 2-day disease, but for example, then our prevalence in San Diego County would go up. If non-cases out-migrate, if we have healthy people leaving, then the number of norovirus cases are going to constitute more of the population. Improve diagnosis and reporting. What if you wrote a paper about health disparities in breast cancer? And breast cancer is higher in high-income countries. And sometimes that can just be an artifact of improved diagnosis and reporting. I don't know whether it is for breast cancer or not. Something that it was a factor for was COVID. Politicians at ham were like, we have the tests, they're beautiful, and then didn't give them out in a way that would have been beneficial because they wanted to have the observed prevalence and reported prevalence be low for political gain. So, increased prevalence can sometimes be an artifact of improved screening. Hear that. Factors that decrease prevalence are shorter duration. If you have norovirus for 2 days, you're only in the tub for 2 days. It's a 2-day disease, you're out. Versus diabetes, you're in here for 10 years. Plus. Possibly a life sentence, right? Increased case fatality. If people are leaking out the bottom like this, real quick, then the prevalence will go down. Decreased incidence. If this happens slowly, your bathtub will be lower. Non-cases in-migrate. If the denominator of healthy people in San Diego goes up, then cases will constitute less of the population. Same thing. If cases leave, then that fraction changes. And increased cure rates if this happens faster. Okay, whew! This is, I think, our longest lecture yet. Coming up, Health Belief Model Extra Credit is due on Thursday. If you want to turn that in, I really enjoy reading those. The song analysis that you were assigned last week. Again, it is extra credit. You don't have to do it. It's optional. But you get 10, possibly 10 extra credit points, possibly 15, possibly just 5. Yeah, do that. If you feel like you want to make up some points that you've lost on quizzes or like not take a quiz one time, you could get 10 by doing this extra credit. Enjoy the break between unit homeworks. It is just this week, so enjoy it. Enjoy the break between quizzes. It is just this week, so enjoy it. Quiz 6 next week will cover this week's lecture and next week's, because we're actually going to start doing the calculations for incidence and prevalence, measures of disease frequency. So it's all gonna add together. Okay. Thursday's activity is book club. Bring your book if you have one, if you have it. A physical copy, I mean. I hope that you have the book in some form and have read up until page 290 and will be ready to discuss. It'll be helpful to gain insights from your classmates. I have some... Oh, do I want to say more about that now? No, I don't think I do. I don't think I do. Okay. That's lecture for the day. I'll stay for questions to the tune of the Wordle and the connections, okay? Let's do the Wordle together. What's a good... Please ask questions. I know that this was a lot of content, so please ask questions. We talked about mortality, so today's starting word is going to be death. Okay, ends in an H. Let's do... lunch. I'm kind of hungry. Oh, is it munch? I was about to say Ice Spice. Is it punch? This isn't going so well. Is it bunch? It has to be hunch, right? It has to be hunch. It can't be anything else. Oh my gosh, I've flown too close to the sun. Okay, whoo! Woo! Phew! That was dangerous there for a second. And I'll do the connections. Please feel free to ask any questions in the chat while you still have me. Ooh, a legend. I'm thinking of like a legend on a map. Oh, means? Medium? I'm thinking of stats. Small, medium, large. Grande? Coffee sizes? No, Grande's probably gonna be, it's gonna be like Ariana Grande, Veronica Mars, or something like that. Harry Styles. Swift. These are last names of people. Yeah, pop megastars. There we go. Remote outside. Why am I thinking of just a Slim Jim? I think I'm just hungry. Channel. Things on a TV, it could be. What is proof? And means. Like a way of doing something? Room. The other day I failed this. I feel like in lectures past I've done this really quickly. Yeah, Amy said hunch. You were right. You were right and I was wrong. I feel like these... vehicle means... legend. I'm so stuck on legend, too. I am legend. Okay, I'm gonna guess this. I don't think it's right. Oh, not only am I not one away, but I'm entirely wrong. I'll take suggestions from chat. Outside, remote. Shuffle. Maybe I'll see it in a new way. Vehicle. All right. We gotta start guessing some stuff. Whew. Means remote. Vehicle, proof, legend. Even worse. Channel. Medium. Horrible. We're gonna fail it. Large, legend, channel, outside. Cool. What are they? Method. I was close on that one. Oh, living. Living proof, living large, living room. Unlikeliest chances. As a statistician, I don't communicate that way. Anyway. Awesome. You watched me give a long lecture and take a long L. And, those of you who come to activity on Thursday, I'll see you then. The rest of you, we'll talk next week. Bye-bye.